Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing HIV and AIDS. I was a young doctor in training when AIDS first became prevalent in the 1980s, and I remember the fear and stigma that surrounded it. Thousands of people were dying, and treatments were limited. Thankfully, there's been a huge amount of progress in our understanding and treatment of HIV in the last 40 years, which has turned HIV infection from, frankly, a death sentence into a manageable chronic disease. Today, we'll explore the current state of the epidemic that never went away and what lessons we can draw from it to apply to the COVID epidemic we're living through now. My guest is my colleague, Dr. Joseph McGowan. Dr. McGowan is an infectious disease specialist at Northwell Health and is currently the medical director for the Center for AIDS Research and Treatment at Northwell University Hospital. He's also a professor at the Zucker School of Medicine at Hofstra Northwell, and I'm delighted that he's joining us today. Joe, welcome to Well Said.
Great. Thank you very much, Ira. Thank you for taking time to focus on this other pandemic, which just keeps raging on.
I said in the intro that you were an infectious disease doctor. In the middle of a pandemic means that you've probably been a pretty busy guy the last couple of years. So how have you been holding up?
I've been holding up just great. You know, it's one thing about infectious disease. There's always something interesting, you know, flesh-eating bacteria or a pandemic or something. So we're never bored in infectious disease, that's for sure.
Well, all right. Well, I guess that's a good thing. So let's start with some very basic information. I said HIV and AIDS in my introduction, and those two terms are often discussed together. But why don't you give us a little bit of a primer on how they're related and how they're different?
That's a great question, yes, because it comes up all the time. So HIV stands for human immunodeficiency virus, and that's the virus that can infect one of the most important white blood cells that make up the immune system. We call them T cells, or more specifically, CD4 positive T lymphocytes. We may hear people talk about a CD4 count or a T cell count. And these T cells, they're responsible to maintain our immune system in a normal balance. So that way we don't under or overreact to certain infections or allergies or other exposures that we might face every day. When the number of these cells gets very low and the immune system becomes so unbalanced that it can't react to protect us from unusual infections or cancers that would generally never be a problem to a fully functional immune system, when that imbalance reaches that level, we call it AIDS, or acquired immune deficiency syndrome. It's acquired because it's something that's established by an infection, not through birth or genetics. So not everyone with HIV would get to AIDS if we can diagnose and treat the virus before we get to that level of imbalance. We could prevent AIDS and just treat the HIV infection.
All right. So simply put, HIV is the virus that causes AIDS.
That's right. Yeah, just like, you know, there's COVID, the syndrome, and then there's the SARS-CoV-2 virus that causes it. So, yeah.
Got it. Okay. So I mentioned that I was training in internal medicine in the mid-1980s when AIDS first became apparent. In retrospect, is it clear now that that's actually when AIDS began, or was it around for a long time and just not recognized or not being seen in the numbers that became apparent in the 80s?
Yeah, it's definitely the case that things pre-existed, but there's sort of a reason why it suddenly appeared. So I'll go back in time a bit and talk here about where HIV came from. And I know you and the listeners will probably be interested. Yeah. So there was a lot of excellent work done on this. If people are interested in reading more, by Dr. Beatrice Hahn. And she went back, she did genetic analysis of the HIV virus and its closest relative viruses that were out in wild living chimpanzees and gorillas in West and Central Africa. And these are where the origins of HIV came from. And they found there were four different instances when this chimp, or at least one time when a gorilla virus passed from these animals to humans. Now, the chimps had developed their immune deficiency viruses were highly adapted. They've been in these chimpanzee species for many, many, many years. And there's 40 different types of chimps. Each one has their own type of immune deficiency virus. Some of them actually cause AIDS in the chimps. So humans aren't the first species that developed AIDS. And sometimes, interestingly, the virus adapted so well to these chimps that it didn't cause disease at all. And so they were really actively under study. How do we do that? How do we decouple this infection from the disease? And that's an area of research. We're trying to learn that from these chimps. So probably the earliest time that HIV was found in humans was 1959. They looked back over samples of dried blood that they had collected in studies in the Congo, and that's the first time it showed up. But they did, by this genetic analysis, they went back and they found that the HIV-1, the virus that caused this worldwide pandemic, probably evolved somewhere in the 1880s to the 1930s in Central and West Africa.
So that raises two questions I have. So if it's been around since then, why did it only become a clinical issue that we've all been talking about since the 1980s? You said it's been kind of prevalent in other primates. How does it get from a chimpanzee to a human?
First of all, it made this jump from chimps to humans because of the way people in those days would hunt and trap chimps, and they would sometimes use them for food. So that was probably they came through blood contact. If you had a cut on your hand, you were handling the carcass of one of these animals, for example, or they used them for food too. And so then probably what happened is during the 20th century, there was famine. There was a lot of colonial activity where they would be inoculating people with unclean syringes and mass movements of people in poverty and hunger. That caused it to spread from where it emerged in these areas in West Africa, throughout Africa. So they looked back and they found in the 1970s, there was probably an outbreak of AIDS in Kinshasa in Congo. So it wasn't recognized as that. They just saw a lot of unusual infections that developed. Then there's worldwide international travel, relaxed sexual practices in the U.S. and in Europe, et cetera, increased injection drug use. Then people started getting infected. It moved over here in the 60s and 70s, probably through Haiti and then through Europe. And then it takes about 10 years on average for the virus to start to show symptoms. So that's when we started seeing these initial cases, the people who progressed more quickly showing up in the early 80s, and then this huge explosion that occurred in the late 80s and 90s as this buildup started to catch up, and the incubation time between what we call latency, where the virus was there but it wasn't causing symptoms, and then all of a sudden this rush of infection, of disease started to show up.
I suspect a lot of our listeners don't have a clear memory of what that initial kind of explosive period of HIV infection and AIDS was like. Can you just put some numbers on that for us? Like how many people were getting HIV and AIDS and how many people were dying from it?
Oh, yeah. So, I think there have been over 675,000 people that have died in the U.S. from HIV. And during, there was a change in the whole definition of AIDS because we needed to catch up. So around the mid-1990s, the definition changed. And we were having, over, 50,000 new infections a year. And even now, with our great therapies, with that rate is still 35,000 new infections every year. We sort of plateaued in this range. And there's still about 13 or 15,000 deaths a year in the United States. Worldwide, there's 1 million people dying every year from HIV with 1.5 million infections. So we're still in this expansion phase where we have more people getting infected. Luckily, the treatments are keeping them alive, so there are less people dying, but we're still actually expanding the epidemic.
Those numbers would probably be surprising to a lot of our listeners. So I just want to verify what you just said, that worldwide, 1 million cases a year or 1 million deaths a year?
1 million deaths, yeah. There's 1.5 million, 1.5 million infections every year and almost 1 million deaths.
Well, we'll talk a little bit more about treatments. I just want to ask, the very basic question, is the reason why we're not seeing that or not seeing it to that extent in the United States just because we have access to better care than is true in many parts of the world? Is that the distinction?
That's definitely true. And, we've done, especially New York State, for example, we created a strategy to end AIDS. So we have the pillars set up. The first pillar is get everybody tested. The next pillar is get everyone who's positive in care and keep them in care. And then the third pillar is anyone who's at risk, get them preventive therapy. So with these pillars, we've been able to bring around the pandemic, at least in New York. It's still struggling in other parts of the country, especially the Southeast. And worldwide, they were saying it would take $29 billion a year to accomplish this world strategy to end AIDS. And, if I can get on the soapbox for a little bit, we spent $40 billion a year on the Afghan war for 20 years. So we could do it, if the world got together.
Yeah.
It's something we could finally put an end to.
Yeah. So let's go back and talk a little bit more about the disease itself before we get to some of these effective strategies for limiting its impact. I'm sure that most people know that HIV can be transmitted through sex. Are there other common ways that the virus is spread?
Oh, yes. The other most common way is through injection drug use, in which needles or injecting equipment is shared between individuals. Some people try cleaning with bleach. That can help, but it has to be consistently done. And, using big, sterile needles is really the best way. Getting HIV through blood transfusion or organ transplant is exceedingly rare these days. All the organs and bloods are screened and tested for HIV prior to, so that really shouldn't be a major concern. And then, of course, HIV can spread from mother to child, and with proper prenatal care and use of anti-HIV medication by the mother, that could be eliminated. And New York State has effectively eliminated mother-to-child transmission. There's only been a couple of cases since 2017. And again, using the same strategies, testing all the moms, getting them on treatment, giving preventive therapy to the newborn. This has really been very effective.
Other than injection drug use and sex with an infected or potentially infected individual, are there other risk factors that make somebody more susceptible to getting HIV?
Yeah, within sex, having sex with more than one partner, and then the type of sex, really men who have sex with men being at higher risk. Even persons who have a single partner could still get HIV depending on what their partner's risk behavior is. So you may not even recognize your own risk. Young adults and adolescents are the ones who are least likely to recognize their potential risk for HIV. People of color, especially young men who have sex with men, and women are disproportionately at risk. And then, you can have sex if you're having sex within a certain population or community that's at high risk for HIV. So if you're in an area of a low-income area or area, where people of color are more likely to be infected, you may not have to have many partners, but you'd still be at higher risk because you're more likely to choose a partner with HIV because the rates there happen to be higher. So sometimes that risk can't be really apparent.
Interesting. So you mentioned men who have sex with men. Is that a consequence of the prevalence of the disease in that population, or is it something about the homosexual sex act that makes people more likely to contract HIV?
So again, where HIV concentrates, and it concentrates in certain communities for reasons. So we're seeing now mostly young MSM of color, men who have sex with men of color, because, again, this idea of prevalence. So once it gets within a community, and yes, sexual practices, obviously there's no risk for pregnancy, so some of that disinhibition is not there to have sexual connection with other men. Also, if you're the receptive partner, let's say during anal sex, that's a much higher risk situation. Also, if there's other sexually transmitted infections around, those can increase the risk of acquiring or transmitting HIV. So if you have a population, again, like young men, young women, where sexually transmitted infections are common, that's also going to fuel this HIV transmission.
Right. Okay. So you mentioned the sort of techniques that are being used at a population level to limit the impact. One is testing, so people know if they're infected. And then you mentioned preventive measures. Could we review what some of those preventive measures are?
For a person who's at risk for HIV, really one of the most important ones and one of the greatest advances we have is something called PrEP, pre-exposure prophylaxis. And that means taking medication regularly to be ready and fully active in the body that could block HIV from establishing infection at the time of an exposure. And it should be used by anybody who is or feels they're at risk for acquiring HIV through sex or injection drug use. It could be 99% effective if it's used, every day as you're supposed to. It's very well tolerated. It's available. PrEP is now available in 2 forms of a daily pill or an every 2-month injection. And so for those people at low or intermittent risk, where they don't necessarily have to take the pill every day, and the risk of getting HIV may not be high all the time, they could take some people could take PrEP on demand, where they just take it before and for a few days after a sexual exposure. And that's really for men having sex with men or trans women. Or if an unexpected exposure occurs, or let's say after rape, for example, PEP or post-exposure prophylaxis, in which the meds are started immediately following the exposure, then for a month afterwards. That could also prevent HIV from establishing itself.
In both of those instances, how effective is that strategy?
So if the on-demand PrEP is used effectively, it can be very effectively, over 84%, 90% effective. The key is to use it correctly. And then for PEP, again, highly effective. The studies that were done for PEP were done among, occupational exposures, and then it's sort of, carried over to sexual contact. And there it's, almost 100% effective if you use it right.
Yeah. Obviously, people can find out if they're HIV infected by getting a simple blood test. But what are the symptoms of initial HIV infection? So how would somebody find out that they might have gotten HIV short of getting a blood test that says, hey, you've been exposed or you've been infected?
Like I said, obviously we want to diagnose someone with HIV before they end up getting sick or have symptoms, and that's why everyone should be screened. But when a person first acquires HIV, they often, very, very often have symptoms. A lot of times they go undiagnosed, but they almost always have some symptoms. In the first few weeks, they could have fever, swollen glands in the neck, under the arms, the groin, anywhere in the body. They could have diarrhea. They could get a rash, mostly over their arms and legs, but also over the body. They can have a sore throat. Basically, it could be almost any what we call viral syndrome, even COVID. And we did see some people with acutely just acquired HIV that were misdiagnosed as COVID, in the early days of COVID. So if it's not diagnosed, those symptoms would just resolve on their own. The virus goes into hiding, and the person could go on for years without any sign. And then almost everybody eventually, though, if they're not diagnosed, they will eventually get sick. They could start up having some weight loss, chronic diarrhea, thrush, which are white spots, yeast spots in their mouth, candida, could also be in their esophagus, the swallowing tube. They could break out with shingles, or they could have unusual infections in the lungs, coughing, shortness of breath. It could affect the brain. People could have seizures, paralysis, memory loss, visual loss. It affects the eyes, the kidney, the liver. Essentially, any organ could be affected over time because of this, imbalance that occurs in the immune system.
Yeah, so that's what we're trying to prevent, that progression from infection to symptomatic disease. So what does that look like today? What's the sort of contemporary management of somebody who is newly diagnosed with HIV?
Well, the key thing is to get them immediately started on effective treatment. And there's so many good options now. And what that does is it brings the amount of virus in the blood, which can be super high in some individuals, especially the ones who get sick very quickly or if they've just recently been infected, the level of HIV can be very high in the blood. And it brings it down to an undetectable amount, shuts the virus down. It can do that very quickly within a few weeks. We can't eliminate HIV from the body, but we can completely turn it off, suppress it, put it to sleep. That will then allow the opportunity for the immune system to get rebalanced, restore the health, and then the person just stays in their meds and keeps, I always say, like, if you have a lion that's loose out on the plains and the gazelle, has to be afraid. When you put the lion in the cage, now the gazelle can go out, they can eat, they can relax. So we're putting this lion in the cage, and it's just got to stay in there, and that's what the meds do. They, keep the cage locked.
I vividly remember the days when HIV infection was a death sentence, that everybody progressed to AIDS and everybody who had AIDS died. It was a horrible period of time in our collective medical history. What's the prognosis now? With these medications that you were talking about, so if you get the lion in the cage, how long can you keep him there?
Yeah, well, we can keep them there forever. The key thing is, when you get a person on HIV meds, as long as they tolerate it, we can keep that virus undetected. It's a challenge for some because you have to take the medicine every day, and it requires a high degree of adherence to the treatment. But if you can get somebody to rebalance their immune system, they could approximate a normal life expectancy. So the key is, if you want to sort of get that balance back, the sooner we start meds, the better. So it's better to get diagnosed when your immune system is just a little bit out of balance than when it's already at AIDS level. You could still get back to balance. It just takes a longer time to heal. So the sooner you get diagnosed, the better. The other great thing about our treatments is once that virus is undetected, it can't be transmitted through sex. So we call that U equals U. Undetectable is untransmittable. So that really, I think, destigmatizes a lot of, things behind HIV, because not only can you get the virus totally under control with really taking simple medications every day, and now we even have injectable medicine that you only have to come every 2 months for a shot, and in the future there could be even less frequent. And then you get an added benefit of not having the stigma of transmitting virus to others through sex. So we're in a very empowering time for people on antiviral therapy right now.
And I guess the other benefit is that inability to transmit obviously has implications for the progression in the community, right? So if more and more people get to undetectable levels, it sort of short circuits the transmission.
Yeah.
Are there long-term negative consequences of taking these drugs? Obviously it's a great thing. You've turned a deadly illness into a chronic manageable disease, which is just kind of miraculous. Other than the sort of challenge of remembering to take your medications, are there long-term consequences of these drugs?
Well, it's a lot better now than we used to be. Currently therapy, to get through the door, it has to be over 90% effective. And by effective, we mean tolerable and effective at keeping the virus suppressed. And so we learned from the older medications, that used to cause effects on the body. So it changed the body fat composition, and it could, someone could be totally healthy, but they could look sick because they had lost fat, etc. So we've learned about those, which, what was causing that. And so all the new meds are scrutinized for those effects. Somebody in care routinely has their kidney liver test monitored for ongoing safety. And that's been really the transformation of care, from the days when we just had medicine that would keep your foot in the door, of the mid to late 1990s. Then we had a period of high pill and long-term toxicity issues to our current period where very safe and simplified treatments, and going into the future, I think even more simplified treatments. Instead of using multiple triple drugs, we're down to like 2 drugs at a time. Long-acting therapies are coming out. So this sort of transformation has been going toward more safe, more effective, less long-term complications, which has really been one of the incredible advances, I think, of medicine in the last few decades.
Without a doubt. Although, let me challenge that notion just a little bit, because what you're describing is building a better and better cage for that lion, to carry forth your metaphor, right? A cage that's easier to take, has fewer side effects, but the lion's still there. Is there any hope of actually, again, at the risk of stretching the metaphor, killing the lion, curing the disease?
Yeah, absolutely. This has obviously been an area of great interest for quite a while. There have been now 3 cases of cure of HIV, but they've been very similar cases. They've been people who had blood cancers, leukemias, who required bone marrow transplant to kill the leukemia, to eliminate the leukemia. And they were able to find, so in order for HIV to infect the T cell, it has to hook onto 2 different proteins on the surface of the cell. And some people are naturally born with only one of those 2 proteins, and they can resist infection by certain strains of HIV. So they were able to give bone marrow transplants, rebuild the immune system of these individuals who had cancer with donors who had lacked this second protein on the surface of their T cells. So that led to long-term cure for them. So it's not really a practical thing for most people, because obviously even just getting a bone marrow transplant, if you don't need it, could lead to death. So we have very safe meds. So I think the trade-off of taking a pill or getting a shot every few months versus that is too high a price. And first of all, we don't have the capacity to do it. But they are taking the lessons learned from that to develop other strategies for cure. So, for example, they're taking people's T cells out, treating them to clip the gene for that second protein, and then giving their own cells back again. And they're trying to see if they could repopulate an immune system that way. It has only gotten around 20% of the cells growing effectively, so they're trying to enhance that. They're also giving, let's say, monoclonal infusions that will certain types will just suppress the virus, but other types are trying to get at this residual virus. What happens is, unlike COVID, HIV takes its genetic code and sticks it inside the chromosome. So there are some T cells that are like Trojan horses. They're carrying this gene around. But the medicine puts them to sleep, so there's no way for the immune system to tell a cell with a bad gene in it versus one that doesn't. So these monoclonals might be able to hang out, and if that bad gene lights up for any reason, it could eliminate the cell. And they're doing something called CAR T cells, which also reprogram the immune system to try to go in and attack those cells that have the hidden gene inside of them. So like use the immune system to get rid of it. So there's a lot of interesting strategies out there that have been tried, to try to wake up or, eliminate those cells that are harboring this extra gene, the HIV gene in it. So, we're hopeful that they will bear fruit, and there's a lot of interest.
Obviously, a lot of our listeners have become more familiar with viral infections and how to prevent them by living through the COVID pandemic. So we have COVID-19 vaccines that were developed in under a year, but HIVs have been around for 40 years. So why is there no HIV vaccine?
That's the million-dollar question, and I get that all the time. So, the differences are a few. So I mentioned one of the big things is that HIV takes its gene and it sticks it in the chromosome, whereas COVID doesn't do that. So once you eliminate COVID from the circulation, you basically got rid of it. But with HIV, we make the virus undetected by our medicine, but it still hangs around. So even if we wiped it out of the bloodstream, it would still be there. And the other probably even more important reason why we can't get to a vaccine is the high rate of mutations that HIV goes through. So HIV is constantly mutating. So the immune system makes a neutralizing antibody, the holy grail for COVID, it makes it all the time. But then the virus just changes its code. And so the body has to make another antibody, and then it changes its code again. So it's this constant wave of antibody, but by the time it's in, the virus has already moved. It's like squeezing a balloon on one end and it pops out the other. So we're trying to find a way of getting a vaccine to some central part of the virus that can't mutate. Like if it mutates there, it's dead. And they have these areas, but the virus covers them. They're deep down inside, so they don't expose it readily to an antibody or anything like that. So they're trying to generate these broadly neutralizing antibodies that will work against strains from here, from Africa, any strain that might develop in the body. But there's no one vaccine that could do that. So they're actually developing a strategy. They've put a lot of the vaccine research on hold now, and they're developing a strategy where you're going to try to train the immune system to go down a certain pathway by leading, let's say, a trail of breadcrumbs, a series of immunizations, of vaccinations, to bring the immune system from point A to B, then B to C, C to D, etc., through a series of vaccinations trails to try to develop this neutralizing antibody so that anyone's vast immune system would be able to come up with this. Never been done before, so that's an interesting strategy. That's one that's being looked at. Be fascinating if it works.
Yeah, that is fascinating. I wonder if there's anything else that you want to share that you see as parallels between the COVID pandemic and the ongoing AIDS epidemic, or lessons learned, anything else you want to share about the concurrence of these two diseases?
Certainly, we've learned, that there's vulnerable populations that need to be protected, and they're going to be the focus of the next pandemic if we don't address some of the healthcare access, healthcare delivery, especially low-income, highly impacted communities. Building a new clinic, is only sort of part of it, but there's a lot of systemic issues: poverty, education, affordable housing, criminal justice, racism, homophobia, transphobia, sexism, drug use, medical mistrust. All these things require a long-term solution. To me, that's the biggest take-home of the convergence of both of these pandemics.
That's a long list of social ills.
Yes.
And I say that not to minimize that, but just to reinforce the fact that that's a tall order to fix all of those things.
Yeah, and like I said, we can try to deal with it on the back end by treating the illnesses and trying to get meds in there, but it's just it's the next, like I said, the next step. And also we have diabetes, hypertension, everything is affecting the communities, but that's always going to be the biggest challenge, because we're going to have people that are going to be vulnerable to the next pandemic.
Well, you know what? I think we should probably leave it there. Thank you so much.
Thank you, and I do appreciate it. And, I'd like to end on a high note that, we have made a lot of great accomplishments, and we can expect more things to come. And now that we're all virus experts these last couple of years, I hope people will take the time to learn about, HIV, get rid of some of the stigma around it, educate their children, empower them, especially around PrEP, and, understanding that HIV should be dealt with like any infection.
Well, thank you. That is a great way to end, and I'm glad that you gave us a high note to go out on. My guest today has been Dr. Joseph McGowan. He's the medical director for the Center for AIDS Research and Treatment at Northwell University Hospital and a professor at the Zucker School of Medicine at Hofstra Northwell. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.